Good morning. I'm Alfred Sanchez, President and CEO of the Greater Miami Chamber, and I want to welcome you today to our webinar, Navigating COVID-19, which is the third part of a three-part series focused today on the aging population. It has really been a tremendous series focused on this terrible pandemic and what we need to know about it in order to rationally respond to current situations. We're actually looking to perhaps put together a report and publish it to commemorate and memorialize all the learnings. So look for that. Today's session, as the entire series, has been put together and presented by the Chamber's Healthcare Committee, led by Miami-Dade College's Medical Campus President, Dr. Brian Stewart, and FIU's Dr. Eneida, Roldan. Brian and Eneida, I can't thank you enough for doing such a tremendous job and such great leadership throughout this whole process and this whole series. Thanks for engaging with our chamber. Today's session is brought to us by Miami Jewish Health, and I want to thank them for sponsoring it. And I want to give a shout out to my friend, Cliff Bauer, Vice President of Government Relations at Miami Jewish Health, who was actually the past chair of this healthcare committee, and he serves on the board of directors still. So thank you, Cliff, for all you have done and continue to do. I want to recognize our media sponsor, South Florida Hospital News and Healthcare Report, and thank Charles Felix for really being a tremendous partner with the Chamber and with this committee. He's been a tremendous herald of what this committee has been doing for many years. So thank you, Charles, and to the South Florida Hospital News and Healthcare Report. Look, we all know the importance of healthcare. If these past 2 years haven't underscored that, I don't know, you've been living under the rock. Small businesses, however, they've been very challenged throughout history to find affordable healthcare rates. Well, I'm very excited to share with you that the Greater Miami Chamber has partnered with AvMed Health to give the small businesses access to great health insurance at much lower prices. The program is called the Greater Health Trust, and it provides health insurance premiums as low as 30% lower than the rates that are offered on the open market. This is extremely important. Having a healthy workforce, having one with few comorbidities is key to our being able to survive future pandemic, future medical and health shocks. So it's extremely important. We've been working on it for 3 years to put this together. So if you're an employer with 50 or fewer employees and you're interested in finding out more, go to the greaterhealthtrust.org. I think we're going to drop that in the chat box and find out more information. So it has been the case throughout this whole series. We've gathered a very impressive and distinguished panel of experts to talk with us today. And as we get started, let me go over the logistics for today. As you know, your microphones are muted to be able to focus on the discussion. Please use the chat box for comments, networking, exchanging ideas, sharing information, and keep an eye out there because as we move through, we'll be dropping important links and information in the chat box as well. If you have a question for our panelists, please use the Q&A feature. It's only those questions that are going to be floated up to our panelists by Dr. Stewart. So please use the Q&A feature to actually engage with our speakers. The webinar is being recorded, and as usual, later on this afternoon, we'll be posting it on the Chamber's website. All right, with all that out of the way, I'm going to turn over the program over to Dr. Brian Stewart, President of Miami-Dade College Medical Campus. We're really truly lucky to have Brian in our community. He's had a tremendously stellar career dealing with designing and running state-of-the-art simulation labs in healthcare, and he runs one of the best in Miami-Dade College Medical Campus. It is literally a virtual hospital that if you haven't seen it, you need to do yourself a favor, contact Dr. Stewart and book a tour. It is tremendously impressive. Brian, we're really proud to have you serving on the board and leading our healthcare committee. Without further ado, let me turn it over to Dr. Stewart.
Thank you, Alfred. It's a pleasure to be a part of your team and be a part of the Greater Miami Chamber of Commerce. I would also like to thank my healthcare committee. We're very active, and I appreciate their support as Dr. Roldan and I have done these webinars. Our goal of our committee is to recruit members for the healthcare committee industry. So if you're interested in joining the chamber and for membership information, the chamber's membership director, Nellie Hockey's information will be in the chat box. Or you can reach out to myself or Dr. Roldan, and we'll make sure you get the information. By the way, our next healthcare meeting is on December 7th at 9 a.m. and we'd love to even have you as a guest, just to be a part of our great committee. As Alfred said, this is our third webinar on navigating COVID, and it has been such a timely and well-presented series. The healthcare committee, as he mentioned, is exploring how best to create an executive summary and package this information to make available to you. So we will be in touch with you on that, as well as we will continue to build upon this series on how we are living with COVID. So now it is my pleasure to introduce my colleague and our Vice Chair of the Chamber's Healthcare Committee, Dr. Eneida Roldan. Dr. Roldan is the Chief Executive Officer for FIU Healthcare Network. And in this role, Dr. Roldan leads the clinical enterprise that serves the academic healthcare center at the FIU campus and in the community. In addition to the CEO role, Dr. Roldan serves as the Associate Dean for International Affairs for the Herbert Wertheim College of Medicine. Dr. Roldan is the immediate past chair and executive officer and president for Jackson Healthcare System. Her training as a medical doctor has taken her as a student, an educator, and a speaker to areas in the Caribbean, Central, South America, and Asia. Graduating with highest honors, in addition to her medical degrees, postgraduate and fellowship training at the University of Miami Jackson Memorial Hospital and affiliates. She holds a master's in public health and a master's in business administration from the University of South Florida and the Haleem School of Business at the University of Tennessee, respectively. It is my pleasure to recommend my colleague and co-conspirator in all this, Dr. Roldan. The floor is yours, and thank you for all your great work.
Well, thank you, Dr. Stewart. Thank you, Brian. Thank you for that kind introduction. And good morning, everyone. It is truly a pleasure to be here with you again this morning to moderate this esteemed colleagues in this panel on the aging population. We have now completed the part 3 of what I call the womb to tomb, which means that we have actually covered the general aspects of COVID and what is COVID. And then at the last series, we covered the pediatric age group. And today we are ending with our aging population. We all know that since the beginning of COVID pandemic, it had became very evident that the highest prevalence of morbidity and mortality was highest in the 50 and older age group. And still today, that holds true in statistics. As of October 15, 2021, the number of cases in the 50 and older age group is as follows. Between the ages of 50 and 64 years of age, roughly 6.8 million cases in the United States have been confirmed. Between the ages of 65 and 74, roughly 1.3 million cases have been confirmed. And 85 and older age group, more than 700,000 cases have been confirmed. We also know that mortality in this age group is very worrisome. We have lost grandparents, we have lost great-grandparents and loved ones to this disease. Between the beginning of January 2020 and October 13th, 2021, of the 712,000 deaths caused by COVID-19 in the United States, approximately close to 196,000 have occurred among those aged 85 years and older. We know that mortality also starts to increase in the group of 50 and older, evidenced by the statistics as follows. Between the ages of 50 and 64, approximately 126,000 deaths has been confirmed. Between 65 and 74, approximately 160,000 deaths have been confirmed. And between the ages of 75 and 84, approximately 188,000 deaths have been confirmed. COVID has also been the catalyst for increased depression and social isolation in this aging population. We know this is true because of the heightened awareness to prevent exposure to those in the aging population to potentially others that are stricken by COVID. However, there is a light at the end of the tunnel. With vaccines that are in the market right now, now we know that those that are 65 and older that are fully vaccinated with any of the vaccines available, they have a 94% reduction of risk in COVID-19 hospitalizations, which is the key to getting vaccinated. We know vaccines are not 100%, but we do know that the risk of morbidity, disease, and mortality, death, are reduced. But that cannot drive us to let our guards down. The aging population has multiple diseases, and hence the efficacy of the vaccine is reduced. Just a few days ago, we lost a giant in our community. The news of Secretary of State Colin Powell succumbing to the complications of COVID was real. He had a disease of multiple myeloma and Parkinson's, and fully vaccinated, still succumbed to the complications of COVID. Today, joining me for the discussion on COVID and the aging population, we have two esteemed colleagues and experts in the aging population. Our first panelist is Dr. Shaun Corbett, sees Miami Jewish Health Clinical Programs enterprise-wise. And prior to joining the Miami Jewish Health, Dr. Corbett was an assistant clinical professor of physical medicine and rehabilitation at the University of Miami Miller School of Medicine, and medical director of cancer rehabilitation at the Sylvester Comprehensive Cancer Center. Good morning, Dr. Corbett. Next, we have Dr. Haleem Mohammed. Dr. Haleem Mohammed was raised in Brooklyn, New York. Interesting background. He is a former stockbroker and vice president of investments who went on to graduate in medical school and receive his MBA from the University of Massachusetts. He is board certified by the American Board of Internal Medicine and has held medical directorships at various hospitals in the Midwest and South Florida, and currently serves as the regional medical director of an award-winning Medicare Advantage provider, Leon Medical Center. Welcome, Hal. Welcome this morning. Welcome to both of my esteemed colleagues. And I know that this morning will be yet another great session and a culmination of a three-part series of navigating COVID. So Dr. Corbett, the floor is yours.
Thank you, Dr. Roldan. Let me share my screen here. Can everyone see my screen?
Yes. Mm-hmm.
See it perfectly, Doctor.
Yes.
Very good. Very good. Good morning, all. And thank you, Dr. Roldan, for the very nice introduction, and thank you to Dr. Haleem Mohammed as well for allowing me to speak with you both today. Thank you to the Chamber for presenting and allowing us to be here today, and thank you all for joining. As Dr. Roldan mentioned, my name is Shaun Corbett. I'm the Chief Medical Officer of Miami Jewish Health. We are really focused on the elderly and caring for the elderly in our community. We have the largest nursing home in the state on one campus and have over 400 beds. We have assisted living as well as independent living on campus. In addition to that, we manage nearly 1,000 nursing home eligible lives in the community. So we've been integrally involved in COVID-19 and this population from the beginning. What I wanted to show here, and I'll go through a number of slides, and they'll actually dovetail quite well with what Dr. Roldan said in chart view, but I just wanted to give a very high level graphical overview in terms of where we were with the pandemic. And you'll notice on the left-hand side here, we know the pandemic started around March/April of 2020, and you'll see three major spikes from that point going forward: the summer of that year, then the winter in 2020 and 2021, and then most recently on the right, we see our Delta variant spike which occurred in the late summer. And fortunately, we're seeing a downturn in cases in our state. The percent positivity rates around 3.8%. We're seeing improvements and reductions in hospitalizations as well as reductions in deaths. So hopefully we're trending in the right direction. When we think about who's at risk for COVID, for morbidity and mortality with COVID-19 and for severe disease, there are various risk factors, and CDC lists 11 or 12 of those, which we know to be true. There are various studies that have tried to monitor, put numbers behind them in terms of which ones are most significant. That being said, the consensus is generally cardiovascular risk factors and hypertension, diabetes mellitus, and chronic kidney disease, followed by obesity and those who have a BMI over 30, pulmonary disease, folks who have a cancer diagnosis, neurologic disease, people who are pregnant, and individuals who smoke. But by and large, the biggest risk factor for severe COVID-19 and mortality is age. What this slide will show you here is, I'd like you to go to row 2 and 3 and looking at hospitalizations and death, and this is compared to the 18 to 29-year-old age group. If you slide your eyes all the way to the right, you'll see that hospitalization are increased in the 85 and over group by 15 times and a 570 times greater rate of death. And you'll see that each decade, that rate changes from 18 to 29 and significantly increases. So we know age is a significant factor, particularly in our 65 and over. Cumulatively looking, and this data is most recent as of October 13th, the 3 bar graphs at the bottom represent 65 to 85 and over age groups. And you'll see cumulatively, if you add those numbers up, the total deaths since the start of the pandemic, this represents 75% or 3/4 of all deaths in the United States since the start of the pandemic have occurred in that 65 and over age group. Again, just representing the factor that age has and how this has really affected our aging population. Bringing it a little closer to home, this is directly from the Florida Department of Health. And what I'd like you just to focus on here is a 65 and over age group in our own state. The case fatality rate as of October 14th was 9.3%. That's nearly triple or over triple in terms of even the lower age group at 60 to 64. So clearly we're seeing a significant increase as decades increase in terms of that overall risk of death, of morbidity, mortality. Breakthrough infections. A lot has been made in the media, and I think there's been some misinformation and conception in terms of breakthrough cases. And I wanted to just represent and show some data here regarding breakthrough infections. There have been 187 people vaccinated, fully vaccinated in the United States. To date, as of this report on October 12th, there were 7,178 breakthrough case deaths. 85% of those have occurred in the elderly. And as Dr. Roldan said, no vaccine is perfect, but these vaccines are pretty darn good. But again, this elderly population is largely affected here. And we know that to be true. There's a weakened initial antibody response, an immune response, and a waning response in this population as well. But that's still a remarkable number. One point I want to make sure that as we're speaking of elderly and so forth, I do want to make it very clear that COVID-19, while it disproportionately affects the elderly, it is not just a disease of the elderly. And the second point of that is that vaccines do work. And we'll show that graphically here and on some of these charts in a moment. I did want to demonstrate here that the vaccination rates in our own state, at the bottom, you'll see the 60 to 64 and 65 plus were 84 and 89% respectively. And you'll also see on the right that the case rate amongst this group in the last week is also the lowest amongst any age group. So highest vaccinated, lowest new case rate. Vaccines work. This slide here represents the 2 different colors that you'll see. One of them represents 65 to 79 and the other represents the 80-year-old age group. And this is looking at rates of COVID death by vaccination status. The dotted lines at the top represent the non-vaccinated individuals in those age groups. The solid lines at the bottom represent the vaccinated individuals and their death rate in those same age groups. You can see a marked difference between the two. In fact, with that, taking age out of the equation, you'll see that there's 11.3 times greater risk of death for any age group among the unvaccinated compared to the vaccinated individuals. So further evidence that our vaccines are working, even in the elderly age group. Shifting gears a little bit here, I wanted to just touch base in terms of the nursing home and nursing home experience and what that's been kind of locally for us as well as nationwide. So everyone, I think, was watching the news, and nursing homes clearly garnered some notoriety in the beginning, clearly from Seattle and the original cases that were coming out of the nursing home there. And when the data tells us that there's less than 1% of the population resides in nursing homes, so long-term care facilities, yet they account for 35% of the deaths in 2020. That's astonishing. And I think we have to ask ourselves, well, why is that? And I think it takes another question of what role do nursing homes serve in our community? And the answer to that is nursing homes typically care for the infirmed, the frail, the elderly, those individuals who have cognitive disorders, including Alzheimer's dementia, and many of these folks have multiple comorbidities. So by and large, this is a very frail population of individuals at the outset are at high risk for COVID-19, for morbidity and mortality. Secondarily, how do we care for those individuals in our community? We care for them in congregate settings. By the nature of this virus and its spread via respiratory pathway for individuals in close contact with each other, this is a recipe for a major challenge amongst nursing homes and caring for these individuals, vulnerable folks living in congregate settings. This graph here is adjusted based on population and percentages. But what I'd like you to take a look at is the nursing home cases in blue, and they started off higher than the general population, but you'll see that it generally follows a similar trend in nursing homes as opposed to the general population. But you'll notice a marked difference in around February or so of 2021. And this really correlates well, and that curve has flattened since then in nursing home cases. And this really represents the targeted approach of both federal and state governments in terms of rolling out vaccine campaigns to this population and to these facilities. And we participated in that early on and received a supply from the state and started vaccinating our individuals early on as well. Where are nursing homes nationwide today? 85.3% of nursing home residents have been vaccinated. 70% of the staff nationwide have been vaccinated. And although not scientific data or study here, just the numbers above each other can be quite striking here. 706,000 confirmed cases of residents in nursing homes with nearly 138,000 deaths. That's roughly 20%. Compare that to the number of the same individuals who work in nursing homes in those congregate settings. Similar number of confirmed cases, slightly lower, but a markedly different and lower number of total staff confirmed deaths. So just another highlight of how vulnerable this population is. Brief overview of how Florida has done compared to the state in terms of nursing homes, et cetera. We have a number of nursing homes, a very elderly population and frail population in the state of Florida. By and large, I believe that some of the state emergency pathways and things that have been set up for hurricane management, et cetera, have really been helpful to the state and helped mitigate some of the potentially catastrophic loss, although one loss of life was too many. But I believe that's really helped the state kind of navigate through and mitigate some of the loss that could have occurred. Again, on this slide here, lighter colors are less deaths, darker colors are more deaths. So Florida's fared, I believe, moderately well through the entire pandemic. When looking at residents and individuals who live in nursing homes, and this is last data slide, and how they've fared through the pandemic. Blue are number of cases, orange are number of deaths, and this is most recent data as of 10/3. Once again, you'll see as time gone on, this data is reported every 2 weeks. You'll see a significant flattening of that curve. And again, I think that the lower death rate is largely related to vaccination rates, improved infection control policies and procedures, and lastly, due to utilization of antibodies amongst this population, not only for those individuals who have been infected, but for those individuals who are unvaccinated and exposed. We've been utilizing antibodies and administering that in our setting as well. So just briefly, what's been our experience at Miami Jewish Health, and trying not to get into the weeds here. It's clearly been a journey, one that should be documented, I think, for all of us, as Dr. Stewart had mentioned previously, and Mr. Sanchez. One of the most important things is developing strong infection control policies and procedures, and I don't think this can be overstated. The focus on infection control is exceptionally high. Early on, we did have to isolate individuals, stop visitation, and as we progress through this, developing significant and strong testing strategies to identify cases in our setting, isolate those individuals, and then cohort them. And secondarily, we changed our treatment model. We went to unit-based care model where same nurse, same floor, same therapist, same floor, to minimize spread throughout the facility. Be flexible with care delivery. And I think probably similar to most other organizations, telehealth clearly became an option and a treatment mode for us in treating individuals. But with our PACE participants as an organization, we bring those individuals from the community into our center, provide care for them here, and then send them back home. That care delivery model had to completely change, and we essentially had to revert to delivering all care into the community. And that would be physician visits, nursing visits, et cetera. So point of recommendation there is just be flexible with your delivery care model and innovative with that. Community integration, what I mean by that is changing the model and the way that you view your organization as it plays a role with others. And that is really working cohesively with our acute care partners. We work very closely with Mount Sinai, University of Miami, Memorial, Baptist, et cetera. And we developed our own COVID units on our campus from scratch. At one point, we had up to 5 units running at the same time, all with negative pressure, ACA certified. And we made that decision to care for our own, therefore not overwhelming the emergency rooms or our acute care partners, and being able to care for our own individuals in our care model. And then in addition to that, being able to offload individuals from the acute care hospitals who we can care for in our facility to open up beds for those who needed them most. So I think that's been an important part of this pandemic and working together with our community partners. Educate and vaccinate. If you couldn't tell, I'm a huge proponent of vaccination. Dr. Roldan said that earlier, and I think that's really kind of the way out of this, in addition to other measures. But we went to extreme efforts to make sure we educated our residents, educated our staff and family members, rolled out vaccine campaigns, and today we have over 90% of our participants and residents vaccinated, and over 95% of our staff vaccinated. I think that's a key component here. Last, don't forget about the not so small things, and what that pertains to is at the end of all these decision making, we can get very focused on the medical components and new protocols, et cetera, as they were coming out. There's a person at the end of our decision making here, and the social isolation that's occurred through this, the depression, mental health challenges that we have seen have been immense. We've taken various measures to combat that by integrating our social work team, integrating our therapeutic rec team to provide virtual visits for family members. We've shifted activities to outdoors and getting people outdoors. Additionally, we've had clerical services that have been done via virtual telehealth and virtual visits. And lastly was really engaging our mental health team here, our psychiatrists and psychologists, not only working with our residents and patients, but also working with our staff. This has been clearly demanding and draining on all involved. So, it's been clearly a team effort, and hopefully we're working towards the end of it, and hopefully there's a light at the end of the tunnel here, and we're working towards that.
Thank you, Dr. Corbett. Thank you for that incredible presentation, and full of very, very good information. And like you just mentioned, there's nothing that can substitute evidence-based and the real story behind numbers, because it's not about numbers, it's about people, and really educating our public of what really is happening, and specifically with our aging population. So next, we will have Dr. Mohammed, who will continue in the presentation of navigating COVID in the aging population. Dr. Mohammed, the floor is yours.
Thank you, Dr. Roldan. Humbled to be part of this esteemed group of colleagues. I don't think Leon Medical Centers needs an introduction. We are the premier Medicare Advantage system in Miami-Dade. We have a wholly integrated healthcare delivery system that's been often imitated, never duplicated. And I'm just going to go dovetail into Dr. Corbett's presentation. I'll share my screen here. Slideshow. So sort of dovetailing into Dr. Corbett's, I'm going to talk a little bit about managing the impact of COVID and the major concerns that we had in the elderly. To put things more in perspective, just using the CDC data and 18 to 29 age group as a reference, the 65 plus, 75 plus, and 85 plus age groups are 5, 9, and 15 times more at risk of hospitalization, and 90, 220, and 570 times more at risk for death. Now, over 75% of COVID deaths were in the 65 plus age group, but only 20% of Americans are actually over the age of 65. To put things a little bit more in perspective for you guys, compared to an unvaccinated child under the age of 10, an unvaccinated 85-year-old is over 10,000 times more likely to die of COVID-19. The more the pandemic raged on, the more we realized how age discriminatory COVID really is. And I just wanted to go over how we manage the risk to our most vulnerable. So, prevention is the bread and butter of primary care. Our goal, whether we're internal medicine trained or family medicine physicians, it's always going to be to keep you healthy, maintain your health, and prevent existing issues from getting worse. And I'm just going to highlight some of the interventions we implemented here at Leon Medical Centers. So in Miami-Dade, we essentially went through 3 different waves of COVID. And without giving away proprietary information, we did see that our interventions greatly reduced our internal positivity rate, severe illness, hospitalizations, and thankfully deaths at LMC compared to the rest of the US geriatric population. We implemented social distancing, mask use, ramped up hand washing, cleaning, disinfection, well beyond what you would normally see in a medical institution. Initially, we reduced in-person visit volumes aggressively based on the percent positivity rate in the community, eventually going to 99% telemedicine, both in primary care and subspecialty care. And we opened back up as quickly as infection and vaccination rates would allow. We discontinued our Healthy Living Center activities in person. We went to virtual classes available on YouTube, Facebook, and other social medias. And we opened up our Healthy Living Centers back up in very calculated steps. We made sure we were ahead of the curve in terms of PPE for our employees, as everyone had seen what was happening around the country with supply. We stocked up with 6 months of medication within our internal pharmacy to make sure that our patients would not run out during the pandemic. All of our urgent cares remained open with the doctors and nurses, many of whom are emergency room trained providers that were working in staggered shifts to ensure that there was no disruption in care. We were one of the first medical centers to implement at-home COVID testing for patients and started drive-through testing for those with exposures or mild symptoms. We made thousands of wellness calls, making sure that our patients had food and medicine at home. We even partnered with a few local companies for food delivery. We created and implemented standardized COVID testing and treatment protocols across all 7 of our centers with the help of clinical leadership. Our home health team was rapidly expanded. Staffing, supplies, and funding was increased in order to meet the demand quickly for injections, blood draws, and for labs at home. We created our own internal 24/7 doctors on call system where our patients could call and reach one of our physicians immediately outside of normal clinic hours. And our doctors had access to their medical records on phones, tablets, and laptops. And our patients did not have to wait until the next morning, which obviously greatly improved patient satisfaction. And I can attest to that because I was actually part of the rotation of physicians as well. And the patient feedback was just phenomenal. Knowing that 911 would be inundated with calls and delays, we created a relationship with an ambulance company to ensure that our patients had timely transport to wherever the right level of care was for them, at our centers, at our urgent cares, or at an acute hospital setting. Within our urgent cares, we designated isolation rooms for COVID suspected patients to receive treatments and respiratory care tents outside to avoid cross-contamination. We partnered with local hospitals for mild to moderate cases of COVID that would benefit from monoclonal antibody treatment. And those are just some of the things that we did in order to ensure our patients and employees' health and wellness. I did want to talk a little bit. I know we were talking about the mental health and living with COVID. So I'm going to take a moment and let's just go back to the beginning of the pandemic when everyone was starting their sentences with in these unprecedented times. And we talked about the new normal. And many of us were concerned early on about COVID and how it would affect the elderly, especially considering the greater adverse effects from the pandemic, the worst complications, higher mortality, and the other downstream effects like disruption of access to care, difficulty adapting to technology with the use of telemedicine, fewer family and friends as they age, inability to engage in physical exercise or participate in activities, and the isolation, loneliness that COVID brought into their lives. I think what many have realized and what has surprised many of us, especially those in healthcare, is how resilient the elderly population actually is. And generally speaking, and I'm speaking generally, I don't want millennials with pitchforks outside of my house tonight. The older generation tends to have better emotional regulation, feelings of well-being, and reacts to stress more positively. There was actually a survey done by the CDC that looked at anxiety, depression, stress-related disorder, substance abuse, suicidal ideation, and it was significantly lower in the elderly 65 plus compared to the younger generations. Now you take this with a grain of salt, as the study was done early on in the first year of the pandemic. It didn't clarify or capture at the level of environment, whether nursing home, ALFs, it didn't delineate whether there were minorities or those with less resources, patients with dementia who were found in future studies to have a much higher risk of experiencing negative health outcomes. And that non-pharmacological approaches tend to work best in the treatment of chronic stress and anxiety. And we're focusing as a company more on cognitive behavioral therapy, promoting physical activity, improving connections, compassion, and that's really been shown to enhance coping, resilience, and reduce loneliness in all age groups, not just the elderly. As an internist by trade, I believe that prevention is always going to be better than the cure, but you'd be surprised at how many folks will hesitate at an FDA-approved vaccine, but will not hesitate at requesting an emergency use authorized treatment once the disease process has already taken a hold. There is a CDC guideline. I'm going to talk a little bit more about how to discuss vaccines with your patients, vaccines with your friends, vaccines with the folks that are just hesitant. There is a guideline that is evidence-based. It's culturally sensitive, way to speak with unvaccinated folks about getting vaccinated. And one of the first things that I learned in med school was that I wanted to be like the doctors who were compassionate, showed empathy, and were genuinely curious about why patients felt the way they did. And if you take the time to listen to folks, they will generally tell you exactly what you need to know to help them. Culture, family dynamics, circumstances will influence how patients view vaccines. Anyone who's married here knows that arguing and debating do not work. It's wasted energy and leaves both parties upset. You start by asking permission to discuss vaccines. If the answer is no, you move on and remind them that since you are their doctor and care about their overall health, maybe you can talk about vaccines at a future time. You can then spend some time exploring why they don't want to discuss it, with the goal being understanding, not to change their minds. You can then ask them how likely they are to get the vaccine on a scale, and help them talk about vaccine benefits out loud. Especially helps with folks who are hesitant because they've already talked quite a bit about why they don't want to get the vaccine. And then you start by answering their questions or concerns, sticking to the facts. I think Dr. Roldan went through some of these already. 187 million Americans have been vaccinated as of earlier last week. The evidence is very clear that vaccines do reduce transmission and dramatically reduce hospitalizations and death. The COVID vaccine does not result in sterilizing immunity, which means that you can still get infected, but your symptoms may be mild if you have symptoms at all. The good news is that persons 65 and older who received both doses showed a 94% reduced risk of COVID. So we at LMC, we began vaccination efforts much earlier and faster than we expected because of careful planning by the Leon family and senior leadership. I want to say we were at the forefront of healthcare institutions in Miami to hit 100,000 doses of vaccine earlier this year for our patients, employees, and the rest of the community in order to help with this global effort to control the pandemic. So we're pretty humbled to be able to say that. And I just wanted to say thank you to all of you.
Thank you, Dr. Mohammed. Thank you both, Dr. Corbett and Dr. Mohammed, for that incredible presentation. and important facts. And one of the things that really resonated with me was what you just presented, Dr. Mohammed, on the resiliency of the age group, which is extremely important because we understand that we have a good number in our community of the elderly population that they live alone, and definitely that we do see a high prevalence of depression and isolation, yet they deal very well with extraneous factors. So very, very important on that. So I'm going to go ahead and I'm going to start out with some questions, and I do urge our participants to please use this time and send in all your questions in the chat box. And then after I finish a bit of a dialogue with my esteemed colleagues here, I will pass it on to my colleague, Dr. Stewart, who will then take questions from the participants. So I'm going to start first, as a true pathologist, and obviously pathologists, those of you that know or may not know, we are very much in tune with tissue degeneration. And the aging process is a tissue degeneration. So Dr. Corbett, you actually listed all the comorbidities or diseases that are aligned with a much higher prevalence of either morbidity disease or mortality death. But what within the aging process you both have seen that could be more in alignment with that severity of disease and or death? So, because we have, as you know, and hopefully I can count myself, I am getting close to that 6'5" number, but I do find myself that I maintain myself active and with good health and so forth. So what is it between myself and then someone that maybe has other diseases, yet we're the same age? Dr. Corbett, Corbett, can you start? Would you want to take that question first?
Sure. So, good question. I think the first thing that happens in aging is that we see an increase in senescent cells. So cells that aren't as good at replicating or regenerating themselves, and that creates a mild inflammatory state. So we know immune responses. There's really two. There's the innate and adaptive immune responses that occur. And what we see in COVID, how this really affects that is that you'll see it in hyperactive innate responses, which is kind of like our shotgun approach to killing viruses and diseases, and then a hypoactive or less active adaptive response, which is really the targeted response. You'll see higher numbers of virus that can replicate in the elderly, and that's one of the reasons why we can see increased morbidity and mortality in this age group. Secondarily, we know that comorbid factors that we discussed, hypertension, cardiovascular disease, diabetes, which all can be related. We see a higher prevalence of those in the elderly, particularly those individuals who are not active, who have more sedentary lifestyles. So if an individual, someone who's aging, wants to help themselves in this pandemic in that regard, activity, monitoring and having regular checkups with their physician to monitor blood pressure, monitor their blood glucose, monitor weight, and activity and exercise can't be, again, overstated in terms of monitoring and reducing your risk for those comorbid factors that would lead you to increased risk for COVID-19 and morbidity and mortality.
Thank you for that. Dr. Mohammed, would you like to expand or add to that?
I think that was actually a great explanation.
Okay, so I'm going to go to the next question. And obviously, both of you deal with a certain part of the demographics that is very culturally sensitive. And so I'd like to start then with Dr. Mohammed. Have you seen any differences in the impact of COVID within certain different types of special populations, ethnicity, diversity, et cetera, within the aging population?
So obviously, we work with a largely Hispanic population, and unfortunately in the United States, the Hispanic population, I think, was 26% of the entire total population, but 37% of cases. That's a staggering number, and that's a disparity that sort of hits you in the face when you look at all the numbers there. We were lucky that we spend quite a bit of time educating our patients, our providers, our members. And using, education, CDC-based guidelines, we were able to reduce the vaccine hesitancy, and our patient population was vaccinated. I think right now we're close to 90%, and those folks that weren't, we're still working on them as well.
Dr. Corbett, would you like to expand on that, on the population that you see at Miami Jewish Health?
Yeah, so very, very similar to Dr. Mohammed. We've had the biggest challenge I think that we've seen is vaccine hesitancy amongst various population groups. We have, speaking from a staff perspective, we have a largely Haitian population, and as well as Hispanic. So we have seen disparities amongst those groups, and we've even gone as far as bringing in community physicians of similar background to help discuss and break down some of those cultural barriers that have been challenging. But from a COVID-19 infectivity rate and perspective, and those that we serve, similar to what Dr. Mohammed said.
Excellent. Thank you so much. Now let's go to the vaccines. Again, that's the big elephant in the room. And we know that still, with so much evidence base and the facts and the numbers speak for themselves, how it does reduce morbidity and mortality, and specifically in this age group, which has been highly impacted. Is there really, one of the myths out there is, I will not engage for my grandmother or my great-grandmother to be vaccinated because they're so frail. And, we have heard all these side effects, right? Which we all know it's very individual. I can just say that, since we opened the vaccination site here at FIU, one of the COVID efforts that I lead here for Florida International University, I was very proud, and we even took pictures that we vaccinated a 101-year-old. And it was like picture perfect, right? And obviously we also had like a 99-year-old, which, by the way, the family brought her on the day of her birthday to say they wanted her one more year, right? Or many, many more years. So can you kind of elaborate on is it true or not? Is it true or not that there is some sort of, that individuals should worry about vaccinating their great-grandmothers or their grandmothers due to to their age?
So no, in fact, that's the exact population we should be vaccinating. Interestingly enough, in my experience, I don't have any particular data to support this, but in our experience in vaccinating the elderly, we've seen far fewer side effects amongst that group, and again, scientifically and biologically, due to decreased immune responses to the vaccine. So very well tolerated. There are exceptionally, realistically, very little to no contraindications to vaccines. So we support it amongst all of our elderly. If there are significant concerns, we address them.
Dr. Mohammed, anything on your end? Have you seen those side effects of either the first, second, or even third dose? As you know, we are now administering the third dose for the immunocompromised and the elderly, both in Pfizer and Moderna. So have you seen any difference, or would you suggest otherwise?
So if you look at the data, approximately 7,000 folks out of 187 million have been hospitalized or have been deceased after being fully vaccinated. Generally, those are folks with extreme comorbidities, different things that are going on in their bodies that would affect them differently than the healthier elderly population. So when we talk about that, I think we need to look at the 187 million that did not have hospitalizations or death. There are side effects. There are side effects to the vaccine booster. It's similar to the same side effects as the first and second dose. And it's going to be local reactions, itching, pain, redness at the site of the vaccine, which you'll also have when you get the flu shot, or when you're a kid and you get the different vaccines you need to get. There's going to be some systemic reactions as well, fatigue, muscle aches, and headaches. Those are also very, very similar to the first and second dose, and those will generally resolve within 48 hours is what we've seen in our population. And again, I will speak to the resiliency of the elderly. We saw less reactions in our elderly population than we did in our employees that are a little bit younger. So.
Absolutely, absolutely. And that's a good thing as we all age. That's something to look forward to, right? One of the myths that we hear out there about how frail aging process is, and again, how non-resilient, which is really the opposite. We know that in the news last week, the FDA advisory panel unanimously approved now the boosters actually for Moderna, because as we know, the Pfizer booster was already approved, and Moderna was actually approved as a third dose. Again, there's a difference, the third dose versus booster. And within the Moderna, as we all know, the booster that will now be approved probably today or tomorrow is half the dose. In addition, on Friday, the same FDA panel unanimously approved the booster for the J&J. And as we know, and for our participants, please note, be mindful that the J&J vaccine is not the same as the Moderna and or the Pfizer. Moderna and Pfizer are what we call the mRNAs, whereas the J&J is the vector. So I mean, it's very different. Would one of the recommendations that they want to look at and they want to be able to approve is the mix of vaccines, which means whether you had series of Pfizer and then you want to get Moderna as a booster, or vice versa, or even have J&J first as a one dose and getting Pfizer and or Moderna as a booster. Going back to the aging process and going back to the fact that in that population, we have a mix of diseases. Would you, as frontline treating physicians, recommend to this age group mixing vaccines? And Dr. Corbett, I'm going to start with you. And if so, why or why not?
So I would be more conservative on this approach. I would be following what the guidance tells us. That's the way that I practice. So, and the way that we function as an organization. So if both are readily available, which they are in the community, I would recommend if you had Moderna, you follow that up with Moderna. That being said, for individuals who may live in less populated areas and don't have access, and they had Moderna first and Pfizer is the only thing available in their community, as long as the data suggests that there is no significant harm, which it hasn't shown to date, I would suggest they get any vaccine is better than no vaccine as a booster. But given where we live in our community, I would recommend following the guidance, and that is getting the same.
Thank you. Dr. Mohammed, any difference to that?
So if you remember earlier on in the pandemic when vaccines were being released and we were concerned about the accessibility, and this was more a concern, I think, across the world rather than, luckily we live in the United States. I don't think that's going to be an issue, and I would recommend if you received Pfizer to continue with Pfizer, and if you received Moderna to continue with Moderna.
And those are very important points, and I want our participants today that are joining us to understand that, because there will be a lot of confusion out there. I do agree with both of you. This type of population, it is best to possibly to just focus and continue with the same series and type of vaccine. Whereas in the younger population, I believe it would be perfectly normal, and that they could do very well with the possibility of switching from a series to then a booster of another type. So thank you very much for that. As far as the going back to still vaccines, we know we're in the fall. We know the flu season is here, and we have forgotten. We think that everything is COVID. We sneeze and we get an antigen test. That's okay. That's a good thing. Okay, that's going with prevention. We want to know ahead of time whether we have COVID or not, knowing that we now have treatment, right, with the monoclonals, etc., and whether you're vaccinated or unvaccinated. However, we also know, and you both are very aware, that the flu itself, not COVID, has also been a catalyst for morbidity and mortality in this age group. So how would you go about recommending whether to use both vaccines on the same day, again, dealing with that aging population, or one versus the other first? Dr. Corbett, I'm going to start with you.
I think what the guidance currently tells us that you can actually get both on the same day, two different arms, COVID on one side and flu on the other. And I think that's very reasonable. If I had my choice in terms of vaccinating, our patients and so forth, I may separate it by a few days or even a week. There is no direct guidance regarding that, but that's the way that I would focus on that. But you're absolutely right. Flu season is here with the change in mask guidance that's occurred over the last, compared to last year. I think there is anticipation of a higher flu season than we saw last year.
Mhm. Dr. Mohammed, anything on the flu? And obviously, that we all at this time of the year, we basically launch our flu campaign because that also causes morbidity and mortality.
Correct. So if you recall, a few months ago, actually, the CDC changed its guidelines. They wanted us to wait approximately 2 weeks between the vaccines. And now they're saying it's okay to do it on the same day. I like to separate it out a few days just to ascertain if there's going to be reactions, which reaction it was, or which vaccine actually caused the reaction. And that helps with clinical decision making as well. So if it was my grandma, I would say wait a couple of days.
Yes, agreed. Okay, another question, big question, especially with the elderly, and we had that happen actually here at our site. We had this, as you know, the first population that was approved for the vaccines was the 65 and over. And we did, and because we had the percent positive rate in our community so high when these vaccines were launched, we had individuals 65 and over that came in for their first dose. And as we all know, we do not have immunity with the first dose. It takes approximately 10 to 14 days to be able to be covered or protected. And then the second dose, and then it's not until that second dose, till approximately 14 days after that second dose, that we are fully vaccinated. We here at the site had cases where we had an elderly come in for the first series. Of course, we know that Miami is a multi-generational city where families live together. And so you've got the youth that would still continue to go out without a mask and came home and gave grandpa or grandma COVID. And so between that first and second dose, they had COVID. What would be your recommendation? Do they get that second dose, and when? How long do they wait? I'm going to start with Dr. Mohammed on that.
So remember, the CDC says that as long as you are able to be cleared from quarantine, you can receive the second dose, even if you've had COVID in between.
Correct. And Dr. Corbett, would that be also your recommendation as well?
Absolutely.
Absolutely. And that is one of the things that, a lot of that vaccine hesitancy will say, I already had COVID. There's really no reason for me to go ahead and get the vaccine. So for our participants today, yes, if you get COVID between the first and the second dose, you still can get vaccinated unless you have been treated with monoclonal antibodies, which then the guideline states that you have to wait 90 days for that second dose. So the message is you get that vaccine as soon as possible, just like now you should be able to get your booster and or the third dose as soon as possible. Big question. I don't want the vaccine, and I don't want the vaccine to be administered to my loved ones because these vaccines are still experimental. They were rushed to the market, and I am not a guinea pig. Dr. Mohammed, I saw you smile. You probably heard that.
Well,
So
I think all of us.
How do you tackle that one?
I think all of us as physicians have heard that over the last couple of years. And the one thing I do want to remind the general public and physicians as well, the method that they use to create these vaccines has been around for years. It was years in development. They didn't skip any testing steps. And if you think about it, we are, and I hate using this word, we are in unprecedented times. So the resources of the entire world were focused on getting this vaccine developed. So it's not experimental any longer.
Dr. Corbett, anything you would like to add to that?
Sure. I think I completely agree with Dr. Mohammed, and the scientific rigor that went into developing the vaccine as well as evaluating its efficacy. There were no shortcuts taken. There were some steps in terms of bureaucracy that were fast tracked, But from the scientific perspective, there were no shortcuts taken. So these are very effective, very safe, and I completely agree that I do not believe them to be experimental.
Excellent, thank you. One last question, and that is something you all touched upon, and it's a very, very important, is mental health. And we know that mental health it's not anymore isolated or just because we are our aging population. It has hit across all age groups because of the multiple changes. And we know, us here as physicians, that even within our colleagues, there's a lot of burnout, depression, and emotional maladjustments, etc. So what would be your different advice to the public, to those that have that may not have the elderly population, the mother, the father, the grandmother at home, at a nursing home? What are the coping mechanisms that you will advise the families of that elderly? And Dr. Corbett, I'm going to start with you.
Sure. I think in engagement, interaction, I think connecting at any level that you can, visitation in nursing homes is allowed. One thing that we've encouraged all visitation to, we encourage people to visit outside. It just reduces risk of transmission, even if you're vaccinated. But engaging with family members in any way possible, even via telehealth and telemedicine visits, looking at mental health and stress. I think even just getting outside, encouraging activity, encouraging exercise are things that are exceptionally uplifting to this population. So that's kind of what it is. Return to normalcy to the highest degree possible would kind of be the overwhelming theory there.
Thank you, Dr. Mohammed. Any types of coping mechanisms or tools that you're providing, not only the patient itself, but themselves, but the family members, because again, we treat in a family-centric environment, right? So
I'm going to tell the general public a secret the doctors have. The medication is the last thing we want to use when we have chronic stress or anxiety like we've been having over the last couple of years. We try to focus more on behavioral therapy, which is really just talking out issues. Like Dr. Corbett said, promoting physical activity. I know, as physicians, when you come home from a hard day of work, you might want to do some exercise, and that sort of changes your viewpoint on everything. And that improving connections, just getting on the phone with them, whether it's FaceTime, Skype, that helps quite a bit. And still having compassion and sympathy and being able to sort of enhance coping resilience in that way, it really helps reduce loneliness, I think, in like I said, in all age groups.
Absolutely. And I think that the power of resiliency and really being a person who actually is very positive thinking and looking at it from the perspective that things are not getting worse, but that there's always options and solutions is also very good. I want to remind everyone that even smiling and laughing at yourself does increase your positive hormone level. And that is extremely important. So a good laugh also every once in a while is very, very important. So I want to thank both of you. It's not over. Please, I see a few questions on the Q&A, and we have both Dr. Corbett and Dr. Mohammed with us for a few more minutes. And now, again, I am stepping down and I will pass it on to my colleague, Dr. Stewart. Brian, you're on. Thank you.
Thank you. Great job as always. Gentlemen, it's been a wonderful session so far. Thank you for your candid answers. I have a couple of questions. Some of these you have touched on, but I thought that it might be good to kind of reinforce them. The first one talks about that there is much concern about the long-term effects of COVID on older people. What recommendations do you have concerning how to detect these effects, such as depression, and what should be done to help address them?
I can jump on this one. So when we see our patients, whether it's an H&P or whether it's a follow-up, we tend to go through a screening, and we will ask those questions to elicit the response, whether it's in the positive or in the negative, and then we'll sort of guide them in treatment. And the treatments are what we've discussed already.
Right. perfect. Dr. Corbett, anything else?
No, I completely agree. Screening for these individuals and treatments, as Dr. Mohammed alluded to.
Thank you. Our next question, you've also sort of touched on, it talks about the booster shots have been approved with Pfizer for people over 65 and those who have risk factors. They're wondering if that includes younger caregivers and healthcare professionals who are tending to be frail and immunocompromised family and patients. One of you want to comment on that, Dr. Corbett?
Sure. Yes, so it is indicated for those individuals, and the FDA has approved it for those individuals, those who are immunocompromised, those work in healthcare settings as well. So absolutely, yes.
Good. Dr. Mohammed, anything else?
I agree wholeheartedly there.
Perfect. We just had a question come in. When do you gentlemen anticipate Moderna being available for the booster in Walgreens, CVS, et cetera? Do you guys have any input, knowledge on when that might occur? I know that may be more of a corporate decision.
I think within the next couple of days, we're going to see that approval roll through, and I'm sure Moderna is going to make that available across the country.
Good, good. One last question I have. So please, if anyone has other questions you'd like to share, please enter them in our question and answer part. Talk a little bit. Have you found that connecting the elderly electronically via video chat, Zoom, Facebook, etc., can be beneficial? These are challenges in training the elderly, of course. Some of the elements of electronic communication and other resources they have found to be beneficial that are highlighted. Or could you share some of those that have been beneficial and highlight and share those? Being able to see and communicate with loved ones can help emotionally during the times with considerable isolation. So any discussion on technology and electronic media, how that could be helpful?
So I'll touch on the challenges there in training the elderly. And like I said before, I think you'll be surprised at how quickly they catch on and how quickly they can pick up different technologies. And I've seen it in my mom and dad as well, my grandparents as well. FaceTime is very easy to use, and you can initiate it on your end, or if you're talking as a physician to your patient, all the other different modalities that we have, they are also very, very simple to use. As long as they have a good internet connection and a smartphone, we're able to connect with them pretty quickly.
Wonderful. Dr. Corbett, any additions to that?
Nope, I agree with that. Only thing I will add to that is individuals who are have worsening dementias, et cetera, or inability to hold phones or devices. There are stands that are available for those folks, and they may just need assistance in terms of getting things set up, but they are very effective tools in connecting with their family members.
The only thing I might add, my parents are both in their late 80s, and their technology skills are not the best, but my children are very good at helping them. So I think it's a good way to connect grandchildren and grandparents together, and even I can help, but they love seeing the grandkids and so forth. So I think that's another way to help that. As we kind of close down, both of you gentlemen work at amazing institutions here in South Florida. Any discussions about what the future holds, and anything that you want to share with our audience members about where each of your two institutions might be moving that you can share with us in the future? Dr. Corbett, you want to go first?
Sure. So we've been in the community for 85 years, and we have largely been focused on elderly. We will continue to do that. One of our focuses will be expanding in terms of our home and community-based services and expanding our PACE role in the community. We will be expanding into other clinical roles and models as well, and expanding our service lines. We will continue to provide care in our skilled nursing facility and our long-term care facility, but really expanding our home and community-based services is where our future lies.
Wonderful, thank you. With Leon Medical, Dr. Mohammed?
Without giving away too much, because I'm part of the clinical leadership team, I think you've all seen the billboards, the TV ads, and different things, different advertisements and marketing campaigns. We have very exciting things coming in the near future, and plans for very exciting things in the future as well.
Well, from Miami-Dade College's perspective, and I know from Dr. Roldan's, we've worked very closely with both of your institutions. Cliff, from your institution, Dr. Corbett, and Efrain, and all your team at Leon Medical. Our nursing program, of course, is named after you here. So It's our honor at Miami-Dade and FIU to be a part of this, and we thank you guys for being here today. This does conclude our third webinar. Thank you all for being a part of this. We will post the recording shortly this afternoon. Dr. Corbett, Dr. Mohammed, thank you for spending time out of your busy day to be here, and hope everyone has a wonderful day and stays healthy. Thank you. Have a great day.
Thank you all.
You as well. Thank you.